of SICS2. We have our first speaker, Professor Manisha Rathi, who will be speaking on frown versus chevron incision.
Everyone, sir, thank you so much for this opportunity. When I came into this hall, I thought it's the wrong hall. Can't be SICS. So I have to congratulate, sir, you and the whole team, Dr. Sahu, sir, Dr. Boramani, sir, and Dr. Gogate. I don't want to forget Dr. Purvi, and everyone for just doing an amazing job of bringing this surgery to the limelight. So I'm speaking on frown versus chevron, but it'll be mainly chevron because 20 years ago I started with frown, and I decided I don't like a frown much. So we made a chevron. If you're seeing me standing here, you may be wondering, why her? Why is she talking about chevron? I may have been doing the surgery for over 20 years and teaching it, but it is the generosity of the ISMSICS chairpersons and founders who have allowed me to be here and to share my journey with you. So we have a lot of publications and ongoing research and publication also. We cannot ignore the issue of affordability in our country. We cannot shut our eyes to the underprivileged and the magnitude of suffering humanity and people with advanced cataracts who come to us. I'll show you a picture of our OPD after this and all the cataracts. So it is affordable, it's effective, and I do not know anybody who has changed during the course of a surgery from phacoemulsification to, who has changed from SICS to phacoemulsification. I'm having problems in SICS, let me convert to phacoemulsification. Whereas, I do know people who have changed from phaco to SICS, just like I changed from high heels to flats. I do not change from flats to high heels if my feet are hurting. So it can be done in any cataract at any stage, shorter learning curve. There's a beautiful simulator experience that is available, which my PGs have experienced, and they have become very good surgeons after that. Cost is minimal, and you can do it in camps and high volume due to the technique. This is our typical tunnel, which I have improved now after this last publication. So I never did the straight incision because I was told at the beginning frown is better. I started with the frown. I realized frown is giving me 0.8 to 0.1 diopters of astigmatism, so I decided that I have to reduce this, went on to the chevron to keep it within the neutral astigmatic funnel. So irrespective of the preoperative astigmatism, my experience is that you can still use the chevron incision for minimal surgically induced astigmatism, and in the year 2022, in our latest series of cases, it is 0.32 diopters plus minus 0.27, which is comparable to anywhere else, and I don't do the keratometry or the post-op refraction. Somebody else does it so that I'm not biased in my cases. Everything is recorded. So all the studies show that chevron is a good incision. Of course, we know that the size, location, shape of incision affects it, and sir is doing on axis, Dr. Boramani said, Dr. Sahu is doing 2 millimeters, they are magicians. You can start with this, you can try to dream of reaching that stage later, but at least do the best you can. So this is a typical patient who's come, 78-year-old gentleman with hypermature cataract. So I'm trying to keep why we have reduced our astigmatism over the past few years from 0.56 to 0.32 is because now I'm going further away from the limbus. Instead of my usual 1 to 1.5, I'm now 1.5 to 2 millimeters away from the limbus. And the tunnel, as you can see, is ideal. Whatever the staining of anterior capsule is very important in these patients, especially the hypermature. People said you don't do a CCC in SICS normally, so I've shown all CCCs. Even in this calcific cataract, you can see all the stars in the eyes and on the anterior capsule, all the deposits. The CCC has been, and this nucleus actually cannot be rotated into anterior chamber. It is so voluminous. So I had to take an irrigating via vectors behind it to remove it in toto. And this is the end of the surgery. Another similar patient. Again, you see all these incisions. I have measured them. Not too much cautery, not too little cautery. Not too deep tunnel, not too superficial. If you go superficial, you'll have buttonholing. If you go deep, you'll have premature entry, which never works, and the astigmatism goes for a toss. So again, the same thing. The total cost of the surgery is less than $10 to the patient, and if the patient can't afford it, I sponsor it. Because nobody deserves to be walking around with an advanced cataract if they reach us as ophthalmologists. Again, so you can see the tunnel. You can actually measure them, and I'm showing CCC in all these patients because I have this tunnel to work with. I find that the forceps is easier in intumescent cataract, white cataracts, and in hypermature cataracts. So after the hydrodissection, irrigating via vectors is very effective and useful, and IOL can be implanted in the back. This is another person. Okay, This is a recently done case in a younger patient. Younger, I mean less than 70, who come to me, because all my patients are middle-aged, they're above 70 years of age. And this is a younger patient, so I made this 2 millimeter. As you can see, it was actually 2.5 millimeter away from the limbus, which I thought, like, will I get away with it later? Because my crescent was being utilized completely in the side pockets. You can see the whole crescent, you don't need to measure it. It is going there. This person here, 4 millimeter, 6.5. So there was, why I chose this person is the pre-operative astigmatism was 0.25 diopters with the rule, and post-operative induced astigmatism was nil. We have a lot of patients like that now. So he's walking around with 6x6 unaided vision. So uncorrected visual acuity is a big factor. And these are the post-operative results. In case you feel, we just left them like that, 1 or 2 have a small air bubble, so you can see the first post-op day. And the mean surgically induced astigmatism now is 0.32 plus minus 0.27. And these are our expectations, 1 to 1, doctor-patient ratio. This is reality. This is an actual picture from our OPD. This was taken 2 weeks ago. There are people standing on top of people, but our reaction to this, we are grateful, we are blessed that we get so many people who come to us. They bring more people to us. Sometimes they go to another doctor and say, yahan nahi karana, iske paas aao. So you're really blessed for that, and you cannot fly, crawl, or go through this space. Once you're in your OPD, you don't leave until OPD is over. And I'm still learning to provide quality to quantity, and I'm learning so much today. Thank you so much, sir, for this opportunity. Thank you.
Good teacher, and she is a HOD. You have become HOD now?
Sir, I'm head of glaucoma.
Yeah.
HOD is under consideration. Hard years are going on.
Okay, she is very dynamic, and we are happy she is here.
Hopefully you will be there. Next speaker. Paper is there.
Will be coming over the consideration. Under consideration will be coming over.
Actually, you know, na? Thank you. He said it first.
Yeah, may we request Dr. Deepak Mishra, the next speaker. Dr. Chinmay Sahu. Welcome, Dr. Chinmay. Dr. Chinmay is a very well-known retina surgeon as well as a cataract surgeon, and he has won the Best Resident Award at Shankar Netralaya and has also authored books on ophthalmology. Please stand, Dr. Chinmay, sir.
I would like to thank the organizers for giving me this wonderful opportunity. Well, you can imagine, being son to my father, who is advocating SICS all around the world and is a great passionate believer. And I've seen him do magic on the eyes. However, I must admit that because of my training and my comfort, I'm primarily someone who does phacoemulsification for most of my situations. But I have this topic today to show and highlight that how important it is to know how to do a manual small incision cataract surgery and how it can help you in certain tough situations. So I'll be just highlighting it with 2 situations. The first, there's a delay out here. So normally, when I see a brown cataract, and if I feel that this is going to be tough when I do a phaco surgery, sometimes you have this intuition that this is going to be a leathery brown cataract and cracking it is going to be difficult. That's the time when I electively plan a scleral tunnel, and I actually start with a scleral tunnel phacoemulsification procedure. So, give me 2 minutes. And I have actually taken a 5 to 6 millimeter incision out here. I go with the routine pockets so that in case I have to convert to an SICS, I can express it through the tunnel easily. A routine 2.8 millimeter incision in this case. And here I'm using a chop and I'm trying to divide the nucleus into pieces. Now you can make out this is a dense brown cataract. I've managed to get the first crack. However, I'm not able to get the plate to divide completely. However, being a person who primarily keeps doing phaco, you keep trying. And in this situation, I've gone on, tried to create multiple cracks. However, it's not going through. After a point, I've managed to, in fact, take out some of the central nucleus, and all I'm left with is a shell out here right now. Now, by then, I have started getting a feeling that if I don't abort this phaco procedure, I might land up with a complication. So in this kind of a situation, because I've electively planned a scleral tunnel, I have an option to convert. It makes it easier for me to take this call. Please pardon my crude technique because, as I said, I hardly do SICS. And in this situation, I've mobilized the nucleus into the anterior chamber, and then later I've expressed it out of the tunnel using a iris repositor. So this is one example where if you have planned pre-operatively, though you may land up in a mess during the cataract surgery, you can still escape if you've known how to create a scleral tunnel and to take out the nucleus through the scleral tunnel. So this was one situation. The second is where, which will follow this particular video, where I've had an intra-op situation. Now here I'm planning a routine phaco procedure. Now maybe this is not clear out here, but what has happened is at the 6 o'clock position, the rhexis has opened up. And I can, in the course of the procedure, I'm realizing I'm seeing a flap of the capsule moving around. Now at this point, the fear is that it will extend inferiorly and I'll land up with a zonular dialysis and a PC rent. So what do I do? I'm at my wit's end at this point. It's a brown cataract. I said the first thing I tried doing was to see if, I trimmed the capsule a bit so that at least even if I'm doing a phaco, I don't want the flap coming into the probe. After doing this little bit of exercise, I still try to go ahead and see if I can, manage and do a phaco procedure out here. I take the first crack, but this is getting exceedingly dangerous. And, the fear is that at any point, especially because it's at the inferior location, it will just open up and I'll land up with a complete nucleus drop out there. So at this point, I take a call and I convert. Now someone might say that why not just do an ECCE and just convert? A couple of reasons. I do feel that I can still control the astigmatism out here better if I've taken the scleral tunnel. And, I've been doing this for a while and it works well in my hand. So I've taken again a scleral tunnel. The question is now, if you've had a primarily entry through the cornea, and if you again prepare a scleral tunnel, would the nucleus then come out through the scleral tunnel easily? You can see later on that it's not going to be that difficult. So as you would normally do a scleral incision, create the pockets, then I mobilize the nucleus out here, and after a point, what I just wanted to show was that though there was a corneal tunnel to start with, or a corneal incision, it does come out smoothly through the scleral tunnel. And in this particular case, I did suture because I wasn't very comfortable leaving it unsutured, and I hydrated the corneal wound. So these were just two videos just to highlight that though, ultimately a surgeon is a surgeon and he has to have all the armamentarium with him, and whatever is comfortable in your hands is what you should do. But you should also have the option to retrieve a situation and manage it successfully. Thank you for a patient hearing.
Yeah.
Thank you, Dr. Chinmay. They were really difficult cataracts to manage, but that again goes on to show that manual SICS is definitely superior where very hard black or brown cataracts are concerned. Thank you. If you can also wait, so there will be discussion later. So, Dr. Nivian, sir. Dr. Divya Manohar. Dr. Divya. Please, ma'am. And Dr. Aarti Heda, ma'am, if you can have it ready. So.
At the outset, I would like to thank Amulya Sahu sir and Jagannath Boramani sir for giving me this opportunity time and again. I think this is like the 4th time we're presenting this together, sir, in this session. So, being a cornea surgeon, I would be, more interested in correcting the astigmatism, being a refractive surgeon. So SICS can also be as good as phacoemulsification if we take care of the astigmatism part. So because the patient also expects SICS, and we as surgeons also want to give patient the best possible vision. So this is just, I just run through the astigmatism. So we have something called the regular and the irregular astigmatism, and we all know what is regular, and in the regular we have the against the rule and with the rule astigmatism, and again we have the irregular astigmatism where we can have the oblique astigmatism. So how do we manage this? So why the initial part was important is because we should place the tunnel accordingly. So that's why we have to know where the astigmatism is more. So how can we induce astigmatism in patients when doing surgeries? By doing cautery in the wrong way, by not placing the incision in the right way, by modifying the suture characteristics, and also post-operative factors like not using steroids correctly. So pre-existing astigmatism, again, you know, the final astigmatic error largely depends on where your pre-operative astigmatism is. So wherever your corneas are steep, place your incision in that meridian. And cautery, so whenever you do a cautery, make sure you use a bipolar cautery, wet field cautery, and cauterize only the bleeders and avoid the blue zone. If you're going to cauterize without, you know, removing the tenons, you're going to end up charring the tenons, and that is going to lead to irregular corneal wound. So make sure that you remove the tenons completely and then cauterize, and use a wet field bipolar cautery preferably. And excessive cautery again can cause scleral necrosis, which can again alter the outcomes of your incision. And never do a cautery after you've done the incision. It should always be done before doing the incision, because if you're going to do your cautery after you've done your incision and your tunnel, you're definitely going to cause fish mouthing, which is again, your wound will not oppose well, and you're going to have issues. And again, the incision characteristics, again, you have to think of the location, where to place your location, what length, and the configuration of the wound. So location, as I already mentioned, we will place it at the steepest meridian. And the external configuration and internal configuration to a wound. So external configuration, this is the pointer. So, oh, can I? Yeah. So this is the arc length. So when you start from this end and goes along the line of the incision, that's the arc length. And from the point of initiation to the point where it ends, so this is going to be your cord length. So this is very important. So Dr. Manisha made my job very easy by saying that the frown or the chevron incision is the best, because she mentioned rightly about the incisional funnel. So that's a funnel that is an imaginary line, which actually, when you draw two lines away from your cornea, from the limbus, away towards the scleral side, and your tunnel falls within that range, then you're going to have good outcomes. So that's why the frown or the chevron incision is best, because here the arc length is huge, and the cord length, that is this point, is again short, and it is also far away from the limbus. So always ensure that you start your tunnel at least 2 millimeters away from the blue zone. That's where you have to initiate your tunnel. So your external configuration, it's always good to go. I prefer doing the frown incision, unlike Dr. Manisha, who prefers doing the chevron. So you see this, I've not touched the bleeders at the blue zone. You can just avoid that. And always make a smooth incision, and if your scleral depth is going to be too deep, you're going to end up with a lot of vitreous and unwanted things coming out of the eye. And if it's going to be too superficial, you'll definitely have a buttonhole, or you might have a tear of the incision, which is again going to affect your astigmatism, and it's going to affect your final outcomes. So, it has to be very smooth and gentle movements, and you see the pockets that I'm making, and the final configuration should be a squarish configuration. So that's very important. So you can see this. This is how my tunnel is. So it's a square-like configuration here. So again, internal configuration, it has to be only 1.5 to 2 millimeters anterior. When you have to dip and enter. I'm sorry. You have to dip and enter, and your edges also have to be very smooth. And when you dip and enter, you should not have saw-like movements, you know. When you go up and down, then you're going to definitely cause ragged edges internally. And at the limbal region, it's going to be very tough. So you have to enter slightly anterior to the limbal region. So the length of the wound is directly proportional. I mean, it's 3 times proportional to the astigmatism. So that is why we spoke about the cord length and the arc length. So this is the imaginary tunnel that we were discussing about. So again, suture, when you place, don't shy away and don't, refuse to put a suture. When needed, you always have to do it, especially when you have a complication or if you feel your wound integrity is not good, never shy away and always make sure to close the incision well. So when you have to place sutures, which is a rare thing, if your tunnel is good, your wound integrity is going to be maintained in SICS. When you have to place it, always make sure that your sutures, one suture would usually suffice, but in case you've extended beyond what you had planned initially, then in those cases you might have to suture it. So when you suture more than one suture, make sure the suture lengths are equidistant and also the lengths are equal. That way you will not be inducing astigmatism. So here you see when your length is more than the width, then you will be inducing with the rule astigmatism. And again, when your sutures are widely placed, you're going to have against the rule astigmatism. And tight sutures will definitely cause with the rule astigmatism or depending on where your location is. Loose sutures, again, your sutures will not oppose properly and it's not going to. So this is how the suture will cause an effect when it is too tight. So I think want of time. Yeah, so in case you want to, post-surgery, you want to correct a patient with astigmatism, obviously suture, you have to remove the suture at least 2 to 3 months post-surgery. And spectacle correction, contact lens and LASIK surgery is an option, but I don't do it. Yeah, thank you very much.
Yeah.
Thank you, doctor, for the wonderful talk.
Dibya, you have opportunity for research. I think you should give little time for this. The suture is becoming obsolete, sort of. So I think
But when needed, it should really be used. So I will beg to differ from sir. It's not obsolete. Seat belt and parachute is needed sometimes.
If you tell the students, they have that inhibition that I have to give the
Dr. Boramani sir.
Anyway,
Sir.
Because ours is the training institute, sir. For the first 50 cases, we ask all the students to suture it.
I will next time expect a research paper from you. Okay, thank you. Yeah. No, you people are teachers, so some research is expected. Okay, thank you.
Suturing is a dying technique. Like when, I don't know, our residents have problems. If you ask them to, if they are supposed to suddenly suture something, they take hours at a stretch. So it's not like, it's a keratoplasty.
Ours have to do by routine keratoplasty.
Okay, our next speaker.
So we have
Arthi.
Yeah.
Our next speaker is Arthi. Our next speaker is Arthi Heda. She will be talking on Boramani's customized SICS.
And Dr. Aarti is a very young, dynamic leader with numerous roles to her credit. So, but she has been a great pillar of strength in ISMSICS. Please, ma'am.
Thank you so much. So, taking the discussion forward, we have spoken about incisions, we have spoken about astigmatism. So, I'll be talking on a very interesting topic. So, good afternoon, everyone. At the outset, I would like to thank Dr. Sahu and team AIOS for this wonderful opportunity. A big thank you to Dr. Boramani sir for allowing me to present his topic of Dr. Boramani's customized incision cataract surgery. So as we all know, cataract surgery has now become a refractive surgery, and the biggest concern with SICS is surgically induced astigmatism. So I'll start with a scenario. This patient with pre-op astigmatism of 0.13 diopter underwent a small incision cataract surgery. Post-operatively, patient had astigmatism of just 0.17 diopters. So is it possible to not induce any astigmatism with SICS? Let me show you another case with pre-existing astigmatism of 2 diopters who happened to be a VIP and wanted to get implanted with Autofocus Pro lens, which is a multifocal lens without any rings. Presently, they don't have any toric range of lenses. So other eye also had astigmatism of 2 diopter and phacoemulsification was done elsewhere, and patient had astigmatism of 2 diopters post-operatively. So we decided to do SICS for this eye with the aim of reducing the pre-existing astigmatism of 2 diopter. So patient underwent small incision cataract surgery, and post-operatively patient had astigmatism of 0.43 diopters on topographer. Autoref showed the astigmatism of just 0.25 diopter, and subjectively the patient was 6/9 with plano glasses.
Next.
So the published literature shows that the biggest advantage of phaco over SICS is that the induced astigmatism is less, but there are no studies to say how SICS wound modification can lead to desirable results on astigmatism. The principle is very simple. A straight incision leads to astigmatism of 1.25 diopters to 1.5 diopters. When the incision is frowned, wherein the end of the incision goes away from the limbus, the astigmatism produced is 0.75 diopter, indicating that the more curved the incision is, the less astigmatism it will induce. So this is how one can titrate the incision against the pre-existing astigmatism. So after doing many surgeries in last 5 to 6 years, Dr. Boramani says that a straight incision of 7 mm will induce astigmatism of 1.69, and it will keep on going down as the size of the incision is reduced. So if the incision is frowned 1, the induced astigmatism will be just 0.5 diopter, and as you go on making it more curved, it will induce less astigmatism. So if it is perfect U-shaped incision, it will not induce any astigmatism. The temporal incision are away from the optical axis, so that they are not very strong in inducing or neutralizing the astigmatism. So a 7 mm temporal incision will induce astigmatism of 1 diopter, and a 5 mm will induce astigmatism of just 0.4 diopter. If the temporal incisions are curved, then they have no effect on astigmatism. So superonasal and superotemporal incision behave in between the superior and the temporal incision, so accordingly you need to calculate. To have a better effect of incision on a steep meridian, you must center your incision on the steep meridian, irrespective of the shape and the size of the meridian, so that the vector forces are acting equally on both sides of the steep meridian. So the next question is where to sit for the surgery. Whatever may be the steep meridian, you will always get this half circle on both the sides. You can go inferotemporal or slightly superonasal. Operating from the nasal side may be difficult, but it's possible. But you can always fashion your incision on the steep axis. The SIA software can be useful to calculate your own astigmatism. You can put one type of incision in one meridian to find out your average astigmatism. So we will go through few more cases. This patient had pre-op astigmatism of 0.28 and steep meridian is 100. So the incision was taken at 100 degrees and it was extremely curved. So there was hardly any change in the astigmatism. In this case, the left eye was operated. The steep axis is at 40 degree. The incision was slightly curved, taken at superotemporal axis, and it had hardly changed the astigmatism. This is another case of a multifocal IOL. 1.62 diopter of astigmatism has just become the astigmatism of 0.29. This is an interesting case with astigmatism of 3.5 diopter, and the patient was not willing to go for a toric IOL due to financial reasons. A large straight incision was taken and there was a significant reduction in astigmatism, and surgically induced astigmatism was almost 3 diopters. Her incision was almost 7.5 mm on the steep axis. So now we can stop calling it as surgically induced astigmatism and call it as surgically corrected astigmatism. And the technique should be called as customized incision cataract surgery. So thank you so much for your patience.
Thank you. Boramani sir, would you want to give some comments? Meanwhile, Dr. Nilutpara Deuri from Shankar Deva Netralaya, Assam.
Only comment is you become master in SICS with a large and comfortable incision. If you are comfortable in delivering any nucleus through any type of incision, then you start customizing your incisions. Long term, actually in private practice it is very difficult. Many patients they don't come back after 1 year. It is very difficult to assess.
No, sir.
We have done the superior and temporal also, and the longer run, 3 months is taken as the cutoff point, but I have been doing 5 years, 10 years, whenever they come back, we do keratin. And it's stable after 3 months.
In fact, sir, at 3 months, there's been an international study where the astigmatism, it regresses up to 3 months. And at 3 months, there was a study where they did phaco against small incision, and the results improved. At 3 months, small incision performed better than phaco emulsification. And at 6 months,
here we want the opposite, no? We want that thing to stay there. So that
yeah, it stays. So what I'm saying, sir, it regresses and then it becomes stable. And beyond 3 months, between 3 months and 6 months, it becomes stable somewhere.
Okay. Yes, Nilutpana.
So these are the, I'm just quoting.
No discussion now, please. Yes, Nilutpana. Yeah.
Good afternoon, everyone. I'm extremely honored, and my gratitude to Dr. Amulya Sahu sir, the entire team of ISMSICS and AIOS for giving me this opportunity. So today I will be speaking about what we call as Sahu's technique of advanced SICS, and I do not have any financial interest in this presentation. So my gratitude to sir and my mentor, Dr. Harsha, for giving me the opportunity to work in his institute and learn from Sahu sir. I will not go into all these techniques, but what I want to tell you about this modified technique is that the modifications that have come up is either related to the incision, as you have seen from all the previous lectures, and or to the delivery of the nucleus, whether you do a phaco-fragmentation or take it out in toto. So the resultant high wound strength of the MSICS technique enable modifications in incision parameters to minimize surgically induced astigmatism and improve the refractive results. So the aim of my study was to discuss the advanced technique of 2 mm frown incision with 1.5 back cuts on either side, which is known as the Sahu's technique. There has been more modifications to it by increasing the back cuts to around 2.5 to 3 mm. The primary objective being to investigate the pre and post-operative effect of this technique on corneal morphometric parameters, and also assess the influence of wound integrity, intraoperative complications, and the learning curve. So these are some of Dr. Sahu's modified instruments. We will discuss while I'm playing the video. This video is not playing. So once the video starts playing, I would like to explain that we have taken a frown, 2 mm frown incision. You can see the figure. We have taken 2 mm frown incision just 1.5 or 2 mm behind the limbus. And then we have initiated the back cuts from either side of the frown. These back cuts are then from here.
Which one you want to play?
Yeah, this one, or you can, anything, anyone.
So
No, not this one. This is the little ulta one. I've kept it in the folder.
which one you want?
Yeah, this one. Yeah, so you have placed the frown incision, then you have initiated the back cuts. Now when you are doing the scleral dissection or making the pockets on either side, you have to be careful that you are on the same plane. Now the entry into the corneal wound is 6 mm, because I want to go ahead either with a foldable or a PMMA IOL. I'll tell you why PMMA IOL. Because if you create the scleral pockets, it creates a compressible floor, so that the nuclear fragments glides out easily. It makes a trapezy net type of an effect. So here I am using SMV, Sahu's modified Vectis, and on top of it I am giving the viscoelastic substance, and with the visco cannula I am breaking the nucleus into 2 fragments. Now you see this is a 5.5 PMMA optic IOL that I have inserted. How am I able to do this? I'm able to do this because the 2 millimeter backcuts, 2.5 millimeter backcuts that I have initiated, it increases the diagonal length to around 5 millimeter, and the scleral elasticity gives space for me to put it inside. So for those who feel that they don't want to go with a foldable, they can also go with a 5.5 optic PMMA IOL also. So I'll go back to the presentation. I'm so sorry for this. So this is the same problem. आप क्यों नहीं play होता है इधर में? किया है मैंने. आपको उधर में भी play किया है preview room में भी. So you can also do a phaco fragmentation in the bag for taking out gliding out the nucleus. This is another one. Then these are soft nucleus. So here, this is Dr. Sahu's video, where he is using the Khan's chopper to divide the nucleus in the bag and then take it out into halves.
Try kare se.
So when you are encountering a soft nucleus, it is advisable that you use a flat instrument, for example, the iris spatula, to take the nucleus out of the bag. Do not use a cystitome or maybe a Sinski. So you can see it is easily gliding out. You can use the viscoelastic OVD and then glide it out of through the 2 millimeter incision. So again going back.
So the only thing was left to us to divide the nucleus in the bag, and we are not dividing the nucleus in the bag. 90% of my cases I am dividing in the bag, and she has taken one step forward. She is putting the PMMA lens and comparing now the results of 2 millimeter with phaco.
So these are my initial 51 cases that I had done from the visual acuity from the first post-operative day had improved to a logMAR of 0 up to the 6th post-operative day. These were some of the pertinent questions that the audience has been asking. So this remains actually from 6 weeks to 3 months, it remains stable. The mean spherical equivalent of autoref measured astigmatic error changed marginally to 0.5 from 0.4. So you see in the biometry, you see the cylindrical power with 2 millimeter, where I did a 2 millimeter of 0.35, and you look at the topo, it is only 0.4 on the other hand. And this one is a 6 millimeter, where the cylinder was only 0.5, and I induced it to 1.4. So the surgery-induced difference of about half a diopter was achieved when a pairwise correlation was seen. So in another case, it was 0.7, and a 2 millimeter led to an astigmatism of 0.0. This is not even a autoref or a subjective refraction that I'm showing. This is a calculated refraction that I'm showing. So the endothelial cell count also, you look at the CV ratios on both sides, 2 millimeter, 6 millimeter. The CV is within the normal range of 37. The wound integrity, we looked at the wound integrity with the ASOCT. You can also use the UBM. You see that the interface is absolutely good. It is tight, compact, and there is no hiccups, no interface problems in these patients. So definitely I had some intra and post-operative complications in these patients, and the most common intra-op complication that I had was iridodialysis in 2 cases, and post-op was corneal edema in 6 cases. Now why it happened? It happened because I did not give the back cuts initially. I thought that I'll go ahead with a foldable IOL, just 2 millimeter entry, 3 millimeter foldable injector, put it in. I forgot that if I am not giving the back cut, the compressible tunnel is not created. So where the nuclear fragments, when you are bringing it out, you are not actually gliding it out, you are dragging it. And when you drag it towards the mouth of the funnel to engage it, it enhances the vector forces, and it directs towards the dome of the cornea, pulling the entire central zone of the cornea towards the tunnel. So that's what made the problem. I had actually the video, I'll show you later on. So it does have a learning curve because it is an advanced technique, but you need to be perseverant, disciplined, and open-minded in your approach. In conclusion, I have this video is an Ingenuity system that I did. Why I did this, I wanted to see that is it reproducible. Yes, definitely it is reproducible even if you do it in an ingenuity system even after 51 initial cases. It is a refinement of incision. Dr. Sahu's technique is a refinement of incision. It is safer for the corneal endothelium, and the wound architecture allows you to implant foldable as well as rigid PMMA IOL. It is cost effective and produces less carbon footprint. Thank you. The results are extremely gratifying.
Thank you.
And thank you once again. These are my references.
Thank you, Dr. Nilutparna. That was really great.
Thank you, sir. So we are looking forward to the comparative analysis between 2 millimeter SICS and FACO.
Wow.
I hope will come up. So.
Great. All of us are enthusiastically looking forward to it. We had missed Professor Deepak Mishra earlier. We know Dr. Deepak is a professor at the Banaras Hindu University's Medical College. He's a prolific SICS surgeon who will be speaking on the journey of SICS from 10 millimeters to 2 millimeters. And in the AIOC for last 8 years, he has been the backbone of the SSTC, the Surgical Skill Transfer course with Dr. Satanshu Mathur. And of course, he will tell us that FACO and SICS both are very, very popular, and SICS still remains popular in SSTC after so many years.
Thank you, sir, for nice introduction. But I still, what the audit we got from the last 6 years, and there is almost the actual number, both cases are same. The residents' choice for SICS and FACO is almost same. Whatever we market is different, that FACO is the preferred choice or not. For residency training, SICS still predominates over the FACO. With these notes, I will start my presentation. It is nothing but what the stalwarts sitting on the dais or in the auditorium, what they did. I am just going a brief about them, how our teachers and masters led this type of innovation, that from initial 10 mm or 8 mm incision, we are now in a position that we can do SICS with 2 mm of incision too. There is no financial disclosure. Why there is shift from ICC to ECC? Just a introductory method, because we always want something smaller. Here is the one thing where we want smaller. In life, we want everything big. But in SICS is the only platform or the gift from the Indian tradition to what that you go for smaller and be satisfied with what you have. So with this thought, we are moving day and day with some smaller demand. At least we can say our society, and we can go for something smaller thing. And these goals changing time with time. So ICC was initially done just to prevent the blindness, but quality of vision was not much important or not given so much important at that time. Then ECC has evolved into the life of the cataract journey, and it comes to the improvement in the quality and some, but residual astigmatism is still there. Then we have SICS, either we say small incision surgery or the name given by Sahu sir, scleral incision cataract surgery, where we can slightly go for the maintenance and reduce the astigmatism too. And now we are moving in such a condition that we are now reducing this, our own incision and site day by day. These are all the surgical construction and limbus. Dr. Nilutpara just explain each and every point, so I am skipping this. But for what we are reducing, the size is important, and that is most important because we are usually afraid, or what the marketing is done, that in SICS astigmatism is more than the FACO. So whatever the changes and drawbacks for us, as from the tradition, we are now dispersing it, and now there are many studies and innovators like Boramani sir has already did lot of experiment on it, how to reduce the astigmatism in SICS. So these are the typical incision sites and what type of incision we find out and how the wound gap is being created, and with this knowledge we reduce it day by day. And there are the various types of corneal incision also given by the different masters to reduce the size. This is a typical traditional SICS what we are doing with 6 to 8 mm of size. And with this, the nucleus management is important, because as when we reduce the size of the scleral, how you deliver the nucleus. That is the most important challenge to us, and one of the important technique where we can remove this big nucleus by small is by the snare technique. Another one here you can see, because with the help of the snare, it is almost phaco-fractured. Half of the lens is removed first and half of the lens is removed second. So whatever the nucleus size of 10 to 12 mm, it is just reduced to 6, so easily we can remove it by 6. Greater on the phaco-fracture or intratunnel phaco-fracture technique also occur, where we bring the nucleus and pull it and rupture it half in the nucleus with the different stages. And we can see that here, after engaging nucleus in the tunnel, we just compress it and remove the part, and rest of the part is been subsequently rotated and removed. With this, Rawat sir also developed many techniques, and he is the master person in the innovations in the science, and in particular the SICS. He developed a new technique where he can give some remove by the scleral incision of 6.5 to 7, and after that he developed his own software for to remove the pre-existing astigmatism. It is already published in ISO. Anyone can access and learn about his technique. And last one, which is the point of discussion, 2 mm. Sahu sir already, sir's technique was told in detail by Nilutpura. I am not going in detail. But what is, you have to maintain that always give some posterior incision too, as she said about why she had some initial hiccup and that. And we are lucky that just 2 days before this article has been published in ISO, and now it is in market, that what is the post-operative astigmatism. And happy to share you all that whatever the 2 mm incision phaco-fracture have good visual recovery as compared to the 6 mm or 4 mm. And we are already doing multi-centric study on this project of 2 mm, 4 mm and 6 mm. Hopefully in our annual conference we can give some more idea or get tell you what is the status after the seeing the statistical data. Thank you, sir.
Thank you.
Thank you.
Thank you. I think those of you are interested in small, very 2 millimeter and wound modulation must market it as a premium surgery, because then you can charge more. You know, one of our friend is charging 2 lakhs, so at least charge at least 1 lakh, because for surgery, this is, those who have got the confidence and have come to this level, you should not market it as a cheap surgery, because the result is far better than phaco surgery. So you can charge whatever you want.
Our next talk is very, very, very interesting. It's a new progressive IOL innovated by Dr. Jagdish Kakade and Dr. Ramesh Shah. Dr. Jagdish Kakade is going to talk about its science of the autofocus lenses.
Jagdish, the person who is standing is a genius, you know. So listen to him very carefully. He has developed so many machines and so many that this new lens is by him only.
Thank you very much, sir. I am honored to present this talk on the behalf of Dr. Amul Sahu, Dr. Boramani and Dr. Ramesh Shah. We all are together in this research, and we do have a financial interest. Autofocus Pro is an IOL which looks like monofocal but works like multifocal. It is an aspheric polyfocal intraocular lens with vertically progressive optic, just like the optic of your spectacle lens, varifocal spectacle lens. Without any diffractive rings, it is static and fixed in the bag. There is no mechanical pseudo accommodation, and yet it gives you an accommodation of up to 3.5 diopters. This is how it looks. It's almost, you cannot perceive that it's a multifocal lens, but if you do an aberrometry on OPD scan or on eye trace, you will notice the progressiveness. Autofocus progressive lenses, this is achieved by green technology, that is gradient refractive index, so there is no loss of light energy like in the diffractive rings, and there are no photons which are lost. This is the schematic optic. Upper half, upper 60% is for distance, then intermediate and then near, and here you can see that at any size of the pupil, the ratio of distribution of the light always remains the same. And these are the two dialing holes, which are also position indicators to be kept in the upper half of the eye. They also help to drain out the retro IOL visco. Because this is a vertically progressive lens, we have to orient it in horizontal position, and the two dialing holes has to be in the upper half towards the 12 o'clock position of the eyeball. And the serrated zigzag L-shaped haptic, which are inspired from the postal stamp, they engage so well in the fornix that there is almost an impossible rotation after the implantation. And its optic is unique. It's 7.5 millimeters horizontal and it is 6.3 millimeters vertical. So it covers the entire field of vision without leaving any of the zone aphakic, and it does not give rise to the edge shadow on the nasal retina, and hence it is completely free from the negative dysphotopsia as well. Let us see a short video of implantation of the Autofocus Pro. This is designed by Optics, manufactured by Lifeline. Please notice the two dialing holes and the zigzag outer edge of the haptics. It is a foldable lens made of hydrophobic material which is presented in water to prevent the glistenings. Zigzag outer edge of L-shaped haptic gives excellent stability. It's very easy to fold and easy to fold the haptic as well. It will need at least 2.6 millimeters incision because it's large in size, so it won't go from incision less than 2.6. It's easy to insert the leading haptic as well the trailing haptic into the bag. And with Sinskey hook we can dial the IOL, and when we dial, the serrated edges of the haptic clean out the fornix base, and you can see that all the lens epithelial cells are scraped out and it comes out as a debris. The two holes are to be kept in the position of 12 o'clock. Once again, to repeat, this is important because we have to keep the lens, since it's vertically progressing, we have to keep the two dialing holes in the upper half of the eye. And when we do the irrigation and aspiration of the anterior visco, anterior to the IOL, you can see that there is no rotation. Even while doing the retro IOL visco removal, you will notice that there is hardly any rotation. There is no rotation at all. It stays where you put it. You can dial it with Sinskey hook, but once your Sinskey hook is out, it will stay exactly where it is. It's stable even while we nudge the IOL, and it remains stable even when the eyeball is nudged with two stick sobs. No matter how much force you do, whatever nudging, whatever forceful nudging or gentle nudging, it will not move. It's a rock solid rotational stability because of the special haptic design. And these two pictures taken apart a month shows you a concrete-like solid stability. And at any size of the pupil, you can see that ratio of distribution of light for distance, intermediate and near remains the same, so it is pupil independent. The typical refraction, this is very interesting. After the surgery, next day or day after, when you over-refract the patient with anything from +1 to -3.5, the patient's vision will remain same, 6/6 or 6/9. That gives you the amplitude of accommodation. And the nearly flat curve on the DOF on the minus side gives you an indication, it gives us a confirmation that this lens has a pseudo accommodation exactly mimicking the natural human lens of a teenager. And contrast sensitivity is as good as a young adolescent as measured on Pelly-Robson chart. And the MTF function, which is an indicator of the quality of image and the quality of contrast, Autofocus Pro has 72% MTF function. Monofocal lens, aspheric monofocal lens has a function of 80%. And all the multifocals do not go beyond 45%. So this is working, I mean, giving the image quality which is nearly like a monofocal lens. The normal anatomical variations of size and shape of the pupil and position of the pupil doesn't make any difference. So angle alpha or angle kappa has no importance. And there's no optical noise as it is in a diffractive ringed IOL. Hence, it is free from the neuroadaptation. As soon as you put it next day morning, the patient is reading 6/6, N6 and computer by 6. Beyond cataracts, it is also the best choice for surgical treatment of presbyopia, hyperopia, and high myopia, as well as for the closed angle glaucomas. Out of more than 5,000 implanted by a group of 65 of us in last 3 years, not a single patient has complained of negative dysphotopsia. Because of its size, even in a dilated pupil, you cannot see the edge of the IOL. And even in a traumatic mydriasis like this, the IOL border cannot be seen. So this is the reason why it is free from the negative dysphotopsia. And because of its large size, this lens is an ideal choice for various types of natural iatrogenic or traumatic colobomas and for the mydriatic pupils induced by acute narrow angle glaucoma or by trauma. It is also the best choice for kids because these children, they have their progressive myopia. They don't want to wear the bifocal glasses in the school. So the parents have to keep spending on progressive chashma, which is around 8,000 rupees. They have to spend at every 6 months or at every 8 months. Whereas with Autofocus Pro, even if they have to use the glasses, it will be only plain monofocal minus glasses which they have to, but never bifocal, never progressive. It has a very sharp square edge, double square edge ring, so the PCO rate is as low. This is 30 months post-op, and you can see that the posterior capsule is very clean. This is the simulated vision of Autofocus Pro. So there's hardly any glare, any halos, so it can be implanted in night drivers also. This is the box design. And all other IOLs are gems, but the Autofocus Pro, I would say, is the jewel of the crown. Please visit us either at autofocuspro.in, our website, and it is launched in this conference, so you can visit our booth 109A and learn more about Autofocus Pro. Thank you very much for your patient listening.
Yeah, thank you.
Thank you, Dr. Kakadia, sir. You are in many ways Leonardo da Vinci of Indian ophthalmology. You keep on doing something new every time you come.
I have used around 50 lenses and I can vouch for it. The presentation will come in the next conference.
Thank you. One difficulty. Can I ask one difficulty? Right, sir, please. See, this, if I compare the lens which you are talking with our spectacles, say progressive or trifocal, when we look down from the lower portion, our eye moves down, and so we see through the lower portion. But here, you are putting the lens inside, which is inside the pupil. So when I look down, my whole eye looks down. There's nothing, you can't compare that with eye looking down from here. My whole eye goes down, so the lower segment also goes down. So when I look through, it is just the same as I see this way or I see this way. This is one question. Right. How do you compare that? Because when I would like to answer that question. Can I? So do I have a time to answer that? Part of this, when the pupil constricts, when it really constricts, I'm afraid that whether my lower segment, where you are having the near anisha, it might go inside and I don't have near anisha. Oh, okay. Can I?
Yeah.
Okay. So the first question is that what happens if the patient looks up or down? Now the answer to this is that when the patient wants to read, this macula in the brain will find the finest point of focus. So the eye, if you carefully observe, when the patient is reading, the eye moves about a degree up in order to bring the lower segment in a usable area. When the patient is looking at distance, when you are refracting for distance, the eyeball goes slightly down. So within a day, the patient learns how to adjust. I mean, it's an unconscious learning of the mind how to adjust to this. And out of more than 5,000, which has been implanted by 65 of us in last 3 years, not a single patient has complained that remove my lens. So you have to really try it. Use few lenses and you will realize that there is no lens in the world which is better than this lens. I can guarantee you that there is no lens which is better than this lens. And this is not
Sir, you should give one lens to each person in this hall, sir, for them to use.
Now, the answer to this question is that this is a company which is formed by 65 ophthalmologists, investing ophthalmologists. So the company is owned by ophthalmologists, for ophthalmologists, by ophthalmologists. So if we start giving free samples, we will be losing our own money. We are not the business people. But I would strongly recommend that you purchase the IOL, and I can guarantee you that you will not be dissatisfied. That's for sure. None of your patient will be dissatisfied, none of you will be dissatisfied. And the price is 7,500 rupees for IOL, that is including GST. So the net price of an imported monofocal, for the net price of an imported monofocal, you get an Indian progressive multifocal with 7.5 millimeters horizontal optic, which cancels the negative dysphotopsia for sure. So what was the second question, sir?
People can't see.
Right. So when the pupil becomes small, the pupil will not go beyond 1 millimeter, not smaller than 1 millimeter, right? So we have tried this, putting pilocarpine 2%, pilocarpine 1% eye drops, and taking the retroillumination, taking the aberrometry. And I can guarantee you that patient never loses the near vision, patient never loses the computer vision, patient never loses the distance vision. So
the depth of focus would increase when the pupil size decreases. So
yeah.
you're getting an EDOF effect as it is.
Right.
Ramesh, you come here. Because his is the brain, and these two people have made it happen.
You're getting extended depth of focus.
The central 0.9 millimeter has got all the three zones. So that will solve your problem. It has taken almost 3 years to come to this conclusion. No company will be able to produce this lens where 0.9 millimeter has got three zones. That is appreciable.
And the best part is on optical bench, when we test this lens, the modulation transfer function of this lens is very, very close to monofocal lens. In spite of that, it is a multifocal lens. With all multifocal, you never go beyond 45%. This is 70-72%.
And that too for near intermediate distance. If you do the MTF on a machine, for near intermediate distance, it maintains same almost 70% for all three visions.
In a trifocal, I would say the near vision MTF is 14%. Distance vision MTF is around 25-26%. And intermediate. And the distance is around 40-45%. So, I mean, trifocal is nothing compared to this. Even bifocal, multifocal is nothing compared to this. Once you use 4 or 5 lenses, you will fall in love with this lens, and then with me and RC.
Sir. I personally do 7 patients a day.
Sir, I have made 3
I do
observations.
7 patients.
You ask him outside, please.
So we still have 3 speakers, Dr. Boramani, Dr. Maurya, and Dr. Manik Nicholson. So we'll have discussion after that.
I'll take only 1 minute, because the purpose of my talk is that both of them are prolific phacosurgeons, so don't go with the impression that this multifocal or autofocus or whatever multifocal and autofocus lenses are meant only for phacosurgery. It is not like that. You can use it in SICS provided you learn whatever Dr. Arti has shown. If you are able to manage your astigmatism well with the SICS incisions, you can put multifocal autofocus lenses with more confidence, because now you know what is going to be your astigmatism. So all cases I do SICS, and I am a small surgeon doing very few cases. So I'll show you the result of my 23 implants which I have put after Diwali, all these autofocus lenses which were non-serrated. So most of the patients have got 6/9 or 6/6 unaided vision. There was one patient with 6 patients with 6/12 vision unaided. The near vision is excellent in all the cases. Only one patient had little less near vision. One patient N9 and N12. Our chart, our optometrists measure only up to N6. Most of these patients must be going to N5, N4, we don't know. And this N12 patient was having ARMD. So near vision is generally excellent, and this lens is a forgiving type of lens. Even if you end up with some refractive error, the end result is very good. As Dr. Kakade said, there is no dysport of CIAS, nothing. So you can happily implant this. I'm not going to show this video because implanting through a injector might be a little difficult. But for an SICS surgeon, just fold it little with a forceps and implant. No, I think I don't know how much time is there. That's why. Anyway, so, and I feel that mostly the multinationals will start copying this design in future. Thank you. Okay, it's very fine, very fine. It's yeah. So they make very slight variation and copy. I don't know.
Yeah, next. Hello, next.
So Dr. Arvind is Associate Professor of Ophthalmology, AIMS Jodhpur. No?
Additional professor and head at AIMS BB Nagar, Hyderabad.
Oh, Hyderabad now. He was shifted from Jodhpur to BB Nagar, Hyderabad. Thank you, Arvind.
Everyone, thank you, Sahu sir and Buramani sir, for giving me this opportunity. So my talk is this SICS and suprahard cataract. So preoperative measures, the consent and prognosis is very important, and proper A and B scan, especially B scan is very important because we are not able to see the fundus. So we can't tell the prognosis about the outcome after the surgery. So B scan is a must. Proper dilatation. If it is not there, then we can opt for the BHACs or the Gupta's ring or the iris hooks that can be opted. And I do SICS in the peribulbar block with no to minimum pressure. And I always prefer to put the CMC eye gel so that there is no corneal abrasion. So while we are operating, so we have a very clear view in the anterior chamber. Incision size 6 to 6.5 millimeter, frown shape most of the time, superiotemporal. And now we have shifted to completely nasal side incision. We are no more using the bridal suture, not at all. And for the starting of the capsular access, initial sharp nick is given, and then very gentle capsular access using the cystitome, Uttarata, and microcapsular access forceps, especially in the hardest of the cataract. And we are dealing with the Morgagnian or the these milky white cortex is there, so I prefer microcapsular access forceps. And the size is between 5.5 to 6 millimeter, and hydro procedure are very gentle. Regarding the nucleus management, this anterior chamber prolapse using 1 or 2 Sinskey's hook by tumbling technique, and after prolapse 2% HPMC towards the endothelia, this I prefer. And this nucleus can be managed using the Visco expression, irrigating wire vectors or phaco fracture, and snare, and now pre-chopper is available, developed by Dr. Khan. It's a very good choice, but it has a very steep learning curve, so that we have to take care. And now we are not even using the Visco for this Indo expression, we are using the BSS only. And it is a very good result while preserving the endothelia. Only 5%, we have done 53 cases, our sample size is around 300, so very soon we would like to present some place. So this endothelia loss is only between 5 to 7%. So not too much pressure on the anterior lip and avoiding any endothelial touch. Side port I prefer because it keeps the anterior chamber deep, and the subincisional cortex we can remove it by using the side port. And the IOL can be any choice, PMMA or foldable, and viscoelastic removal, it needs to be diligently and patiently done to avoid any IOP surge in the post-operative period, and sealing of the side port and air bubble to maintain the anterior chamber. So it's these are few videos. So very minimum cautery I prefer, as told by other speaker also, minimum cautery. And a frown incision, that is 1.75 to 2.25 millimeter away from the limbus. And the size is 6 millimeter. Then using this crescent, this tunnel is extended in a rectangular shape. So it can accommodate the hard and the large nucleus. 2% over the cornea. And now it's a Modiglian cataract, so there's this milky white cortex is coming out, and we have developed under the leadership of Dr. Raindra Prasad this sieving needle microcapsulotomy technique, and we have won the first prize in the just recently happened American Society of Cataract Surgery. So you can go through that. It's available on YouTube. So now there is no more cortex left. So we'll start with the rhexis part. It's still there. So for better control, in such cases, I prefer Uttrata or this microcapsular rhexis forceps to have a better control. And we can hold it again and again after 1 or 2 clock hour of capsular rhexis. This is how it is completed. It's around 5.5 millimeter, but the nucleus is large. So it's completed. Now prolapse into the anterior chamber using the Sinskey hook. This is how the tucking of the Sinskey hook and bringing it out of the capsular rhexis margin. You can see it is now a slit, so it can accommodate up to this 5.5 millimeter size can accommodate up to 8 to 9 millimeter of large nucleus, because it's now like a slit. And if the anterior chamber is shallow, then I prefer it to be parallel to the iris plane. But here it was deep, so it was vertical, and now removal from the anterior chamber using the wire vectors. So this is how, avoiding any contact with the iris, very gently, and then removal of the remaining cortical matter and placement of foldable iron. So we are implanting even trifocal using the SICS, taking care of the steeper axis in the back. This trailing haptic is stuck, so it can happen. So with the help of the other instrument, Sinskey hook, now it is out and in the back. This is again supra-hard cataract using the BSS only. It's been prolapsed. Now you can see the anterior chamber is shallow with hazy cornea. So all these steps were parallel to the iris plane, avoiding any endothelia touch. This is visco expression of the nucleus.
Hello, yes sir.
This is the last case. So gentle hydro procedures. Prolapse into the anterior chamber. You can see the pigmentation over this anterior nucleus. And now 2% towards the endothelia and removal using the visco expression. And if the suture is required, we are preferring equidistant, a figure of 8 suture. The knot is in the tunnel only. So those kind of suture we are preferring. Thank you.
Thank you. Yeah, next.
Yeah, thank you, Professor Maurya sir, for a very extensive videos.
Thank you, sir.
Yeah, we are short of time and we still have 2 more speakers. I would request Dr. Manik Nicholson, who has been one of the backbones of our SICS training programs, to present the magic of AC maintainer. And then we couldn't hear Dr. Nivian, his SICS with secondary IOL options for 5 minutes. So let's hope we have the time and we are able to do that too. You please be ready, Dr. Nivian.
Good afternoon. Thank you so much, everyone. Thank you, Sahu sir, for this opportunity, and Dr. Boramani for all the help with the presentation. So today, after all of these videos, towards the end of the session, I'll be talking on a very simple topic. I'll be talking about the versatility of the anterior chamber maintainer, very small but easy instrument in small incision cataract surgery. So there are various techniques to skin a cat, but today we'll be discussing a little bit about the Blumenthal technique, which was popularized by Dr. Michael Blumenthal. So there are various types of anterior chamber maintainers available in the market. I don't think it's important which one you choose to use. More important is the technique of insertion. It's usually made with a 19 gauge MVR blade pointed towards 6 o'clock position. One must ensure that the tunnel is not too long or too short. Long tunnels cause a little bit of stromal hydration, making visualization difficult, and short tunnels cause the AC maintainer to repeatedly slip out. One must ensure is that the AC maintainer is primed before insertion. A screwing movement is used to insert it into the anterior chamber, and then it's turned bevel down to face the anterior lens capsule. So we will be in short discussing each of these steps in the role of the anterior chamber maintainer in each of them. So although most of us use viscoelastic to create the rhexis, it is possible to do it under the anterior chamber maintainer. One advantage is that you don't have to repeatedly keep injecting viscoelastic into the anterior chamber. The only problem which you'll see occurs here when you approach the approach the maintainer, where the flap tends to flutter a bit. But if you keep it flat on the anterior capsule and ensure that it stays flat, it's quite easy to complete and get a good size rhexis. Tunnel creation is also, what I do usually is I do the rhexis and then I make the tunnel. So I already have one side port created, and through that sometimes visco tends to escape out. But if you keep the anterior chamber on while creating a tunnel, you get a good depth of the tunnel, and the globe does not tend to soften during tunnel creation. This is an animation showing the same. There's a lot of, the anterior chamber maintainer keeps the pressure within the eye positive, and you don't have a lax scleral wall, and therefore tunnel creation is quite easy while keeping the anterior chamber on. So next is nucleus delivery. What Dr. Michael Blumenthal described was originally delivering the nucleus using an iris repositor. This is what is shown in the first video. By repeatedly pressing the posterior lip of the wound with an iris repositor, one can easily deliver a nucleus. You will also see that there's some amount of bleeding from this wound. However, because the fluid is flowing from inside to out, there is no egress of blood back into the anterior chamber. You can also replace the iris repositor with a sheath glide, which is not what we normally use just because of cost. But one can also use a McPherson's now, which is what I do. I use a McPherson's to press on the posterior lip of the wound, and repeatedly pressing can deliver even hard brunescent cataracts. So the advantages of using it is that it provides a one-way flow. It acts as a tamponade in case of bleeding. There's low turbulence and low flow, therefore less discharge of prostaglandins, which results in less post-operative inflammation and intraocular pressure spikes post-operatively. There was a large study done in a large institute in South India, which compared Blumenthal SICS with ECC and phaco, and they found that the percentage reduction of endothelial cell loss was in fact the least with Blumenthal SICS. So this leaves us with Cortex wash and IOL insertion. Cortex wash is particularly useful to use a AC maintainer for this step because the intraocular pressure is maintained. And therefore, there are less chances of an expulsive hemorrhage. The pupil stays dilated and the bag stays distended, which makes it safer to perform eye under an AC maintainer. IOL insertion requires a bit of a learning curve, at least it did require for me, because the positive pressure within the anterior chamber causes the IOL to repeatedly slip out. But once you get a good hold of the IOL and dial it into the AC, it's actually quite a quick method to place the IOL in the bag, because you don't require to do a visco wash at the end of the surgery. This is a particularly useful tool, especially in cases of complications. You can see that a rent was noted at the time of IOL placement in the bag, and the surgeon has very adeptly and dexterously sort of dialed the IOL back into the sulcus. At no time the anterior chamber maintainer was turned off. This helped pressurize the anterior chamber and help prevent the tear from extending. So there are various variations which have been described in literature of the anterior chamber maintainer. You can also inject viscoelastic, that is what some surgeons do. And what has now recently been described in literature is the use of a trocar cannula to replace the anterior chamber maintainer as well. So some of the pitfalls of visco, which I thought I would list here, were that it is more costly than an anterior chamber maintainer. It can result in post-operative IOP spikes. There have been known cases of TARS induced by viscoelastics, endotoxin contamination. And one of the advantages of the ACM is that you can continuously irrigate medications such as adrenaline and antibiotics via the AC maintainer. So just in conclusion, the anterior chamber maintainer has a lot of advantages as compared to the others, but no one technique is best. Whatever works best in your hands is what you should do, and there's still so many newer techniques which are coming up under the ISMSICS banner, and it would be useful for an SICS surgeon to be adept at all of them. Thank you so much.
Thank you, sir. So my topic is going to be SICS with all the secondary IOL options. So far they've seen all the different types of how SICS was done. Yeah. So I think the previous speaker's last slide was my first thing that I grew up doing a lot of SICS and enjoying the whole surgery, and then changed to phaco and then became a VR surgeon. Now I think the entire SICS has been reinvented by this group of MICS thing, and it's such a joy to be a part of them and learn so much. And as ma'am said, there's so much to learn. That's why I'm not going to describe the SICS part, because the way they do the incisions have changed, how they do it 2 millimeters and all the premium IOLs. So once the SICS is done, this was actually a subdilated hard cataract. So first itself we had actually planned to remove the entire cataract in toto and place a claw lens. So claw lens is one of the best options when you do SICS, and since we are a training center also, we get a lot of patients with whole bag removals and very bad cataracts. So this particular case, I'm going to show you a retropupillary claw lens. Because it was a planned surgery, I don't have the slit lamp because the entire nucleus was dislocated. I actually went ahead and fixed the trocar, but it's not necessary. You can also use the AC maintainer. And now I'm entering into the anterior chamber with the keratome. You can see the entire lens actually bulging out, so there are no zonules. Only superiorly there are like 2 clockers or zonules actually attached and hanging. You will see that when I'm delivering the nucleus. So I can see that there's no nucleus, because if you had some zonular support, there would be some traction there. So except for the superior part, the entire nucleus is almost just going to fall. So either you have a complication of a whole bag removal, or if it is a planned surgery. So once you have an aphakia, a good vitrectomy is a key for any secondary IOL, no matter what type of secondary IOL you're going to implant. And I always prefer to stain the vitreous with tricot, because 2 advantages. One, you can see the vitreous very clearly, and the second thing is some amount of the tricot crystals that actually go back prevents the post-operative CME. So in 2 ways it's useful. So always never hesitate to stain the vitreous. And initially I used the main port because I had some of the bag remnants that was there to clear, but always they say use the side port because you can have it form so that there's no more prolapse of the vitreous. So after a good anterior vitrectomy, so we're going to go place the iris claw lenses. So these retropupillary iris claw lenses are very, very easy to use. The only trick here is I always take my second hand inside first, where I'm going to clip and I mark the area, and then take the lens. So this makes it easier for me, so that I avoid searching that area. See, my second hand instrument is already there where I'm going to clip, and then I lift up the hand which holds the IOL and the left hand pushes down. Because sometimes what happens is when we are actually clipping the lens, the other hand tends to move down. So that is why we say we're not able to clip it. So the simple trick is you hold it with those, and the second thing is those forceps you see, you need to have some broad forceps. So the normal IOL forceps, when you hold it very hard, it slips the lenses. So that is another reason we find it hard to clip. So any of the shepherd forceps or the iris claw forceps that has this broad end, so you can use that. So push it upwards, and then just a small thing, you can see a dimple in this thing. So iris claw lenses are good. If you do it in the mid periphery, you can get these round oval pupils, and only if you come very anterior, you get those cat eye pupils, or you go very posteriorly, you might have some bleeding. So, and you get good amount of dilatation to see the fundus. So iris claw lenses is one of the first options that we have for any of these aphakic patients. And then moving on to the second thing, SIC is another thing is, even though you have a large rent where in phaco you cannot keep unless you have a 3-piece lenses. So this was another case of an SICS. We have planned it as a secondary procedure. Since it was a secondary procedure is why I'm doing a pars plana vitrectomy, because it, in these types of large lenses, it prevents more vitreous prolapse. If you have a small rupture, you can always do the anterior approach, that is the best. But since you can see here, the anterior rim is there. So rigid lens in the sulcus is one of the best options. And as far as you make sure there is no vitreous in the wounds, make sure you swipe and see the entire anterior capsular margin, so that you are sure that the entire margin is there. So once that happens, what I'm saying is, even though if it is a large rent, these rigid lenses in the sulcus are very, very stable, and it can be done. So once you check it, viscoelastic, filling viscoelastic also, don't fill it in the anterior chamber. You can fill it between the gap between the anterior capsular margin and the iris. So what that does is it creates some space for you to put the lens inside between the iris and this thing. And then make sure that the leading haptic, that is the fantastic, make sure that the leading haptic goes inside. You're very sure you're seeing the margins and the leading haptic goes inside. I usually do the 2-step technique where I just stop this thing and I go through the side port, and then the optic haptic junction. So I actually take it and curve it along the iris margin. And then no more manipulations. I just use a Simcoe cannula to actually aspirate some of the remaining visco whatever is used, and I always let in an air bubble. So thank you. And this is a new invention of my lens called the Cmt Flex Lens. So this has a special T-shaped haptic, because initially if you ask me, the last option is instead of doing a sutured lenses in SICS cases. So these lenses have these specialized T-shaped haptics. So you do a sclerostomy and you pull out this haptics outside, the T opens up and that prevents the lens from falling back. So this is also another option where you have an this complication. You can see, I'm just running it for the pass of time. So holding the T junction through the sclerostomy and then gently bringing it out. Once you bring it out, the T opens up, and then now shifting to the other side, holding the head of it and bring it out. So once that is there, you don't know tucking, no suturing, no gluing, because this lens just stays there with those haptics outside. That's the entire design of these lenses. So thank you once again, the entire team MICS, and special thanks to Amalya Sahu sir for always inspiring and motivating us. And
thank you.
That's what I said. It's like reinventing the whole journey of SICS, and nice to see the full. Yeah, thank you, sir. The last one is a hydrophilic material. It's a single piece hydrophilic lens. Thank you. 1.5 millimeters away from the limbus. The overall size of the lens is 14. So as of now, we can do it for normal eyes. So, but if you have these large eyeballs or something, right now we don't have that. But if it's a smaller eyeball, we can do the sclerostomy a little far away, up to 2 millimeters maybe.
What size?
The 23 gauge. So that's why it's like sutureless and.
So I thank all the speakers and audience for having their patience. They have given this time a small hall, and next time it will be bigger. Thank you.
But within a small time, we can cover all the entire gamut of SICS, including complications.